home. Those with increased risks for ventricular assist device support, like systemic RVs, those with complex anatomy, may have a request made for status 3 exception if they are hospitalized requiring inotropes. Single ventricle circulation similarly come in at status 4. The heart transplant organ allocation system is very much dependent on what therapy you're on as opposed to what your prognosis is. So the therapy is used as a surrogate for prognosis. And the single ventricle patients, again, they may get worse on inotropes if they have that liver failure kind of phenotype. They may not be a candidate for an assist device. It may not help them. And they have higher post-transplant mortality. So therefore, those with single ventricles can be upgraded to status 2 if they're requiring some type of IV therapy in the hospital, be it inotrope or vasoconstrictor, continuously in the hospital until transplant. So there are some changes in the current organ allocation system that hopefully will reduce the wait list mortality for those with congenital heart disease on the adult side. There are a number of new things in transplant that may help the CHD population. Donation after circulatory death will increase the donor pool. Right now, the donor pool is fairly fixed. Ex vivo perfusion of these donor hearts is part of this DCD protocol where the heart is perfused in a box. This can also help our congenital patients who have long reconstructions that may otherwise increase the ischemic time on the donor heart. So this ex vivo perfusion is in clinical trials right now, as is DCD. But hopefully down the road, we will have have access to more therapies for our CHD patients. I won't get into this, but humeral rejection is problematic for sensitized patients like the CHD population. And there are new protocols, always new protocols trying to address this problem. MCS, mechanical circulatory support, otherwise known as ventricular assist devices, support about half of patients to transplant currently. And the newer devices fit in the palm of your hand. These centrifugal flow devices can just be put in the apex of the ventricle and do wonderful things without having a big pocket created surgically to hold the device. You still have externalized cables and all of the complications that go with an externalized cable, mainly being infection and thrombosis. In the CHD population, there are some anatomic challenges. The CT scan on the left is a systemic right ventricle in a DTGA patient. And the VAD is in the right ventricle going to the aorta, as is typical. Systemic RVs are heavily trabeculated. They have hypertrophied moderator bands, and all of this can obstruct flow and make the VADs less effective in this population. Often that needs to be addressed surgically when the VAD is placed. In the single ventricle population, you have the question of where do you put the VAD? Is this primarily heart failure and you put it in the ventricle like you would in acquired heart failure? And if you do, can the passive flow through the Fontan to the lungs support the increased cardiac output from the VAD? And if the problem is primarily failure on the Fontan side, so the ventricle is normal, you have to build a venous capacitance chamber to avoid competing flow up and down the inferior and superior vena cava. So at the end of the day, this is a team approach to figure out who's a candidate, how to put it in, and what kind of benefit the patient might achieve. I'll just show you this for fun. Mark Rodefeld in Indianapolis has been working on a Fontan VAD that basically sits at the SVC IVC PA junction, brings flow down from the SVC up from the IVC and out to the PAs. And you'll see that kind of demonstrated here in this video. And you can see it mixes beautifully in this model. Children who have a ventricular assist device for CHD do worse than children who have it for non-CHD indications. And adults who, and this is the blue line, adults with CHD who get a VAD do worse than adults with non-CHD indications for their VAD. At the end of 12 months, about half of adult CHD patients with a VAD are alive. About 28% have died and 20% are transplanted. So obviously this is not a long-term solution for failing CHD circulations yet, and is not a great short-term circulation. Probably its main role is bridge to transplant. Palliative care is an important part of any advanced heart failure therapy discussion. All of our patients who are undergoing evaluation for VAD or transplant also meet with the palliative care team, and it is important to offer these therapies to our patients. And I'll leave you with these thoughts. The Fontan palliation, those single ventricle CHDs are the most likely to need advanced therapy. Fontan failure treatment is best tailored to the phenotype. MCS has a limited role in CHD for a number of reasons, anatomic and physiologic. And transplant for those with heart defects is high risk, but high reward. And I am happy to take any questions.
Thanks so much, Wendy. That was a fantastic talk and review of a really complicated patient population to take care of who has needs that I think that you have done a great job taking care of at Emory. So if people have questions, you can feel free to put them in the chat box, or you can raise your hand and just unmute, and I'll help look out for that. I'm just going to start off just with a quick question. You had mentioned, we were having this conversation recently with one of our systemic right ventricle patients who's on the transplant list, who's status 3, who's waiting. So I was curious if you have any experience with desensitization in your population, or use of DCD, the deceased donors, to help your population, and what your experience has been like with that.
Yeah, it's a complicated question. We have used DCD. We got a CC-TGA through transplant with a DCD donor who did fantastic. Heart picked up immediately. And we offer that to all of our patients. It is part of a clinical trial, so they have to agree to be in the clinical trial to receive that option. But most of our patients are listed for DCD. Most of them opt in, I should say. The sensitization question is a complicated one. So I've learned a lot about HLA antibodies, mostly about how little we know. And the longer I do this, the more I learn about what we don't know. So by way of anecdote, I had a gentleman who had a PRA of 99%, so had antibodies to 99% of HLA antigens. And we could not transplant him at Emory, and we sent his blood to UCLA, which was doing a protocol with eculizumab in highly sensitized patients, and they give that as a dose at the time of transplant. They ran his blood and called me and said he doesn't qualify for the trial. His PRA is 0. And we're like, what, right? So as I looked into this and spoke to centers around the country, some centers do a dilution, and the fluorescence beads that are used to determine what we perceive to be antibody levels and use for our cutoffs for transplant are not quantitative. They are fairly qualitative. So what we perceive to be a high level may not be a high level. And what they do differently at UCLA is they dilute the blood and then do the fluorescence to look for antibodies. And we have learned that some of our patients that we think are highly sensitized are not as sensitized as we think they are once we do that dilution. Most of the therapies we've tried over the years to desensitize people are either short-lived or don't work very well. That doesn't mean we don't still do it. We still do it. But I'm not sure that we have stumbled across anything that really enables us to get people to transplant.
All right, I see a question from Yibing. Go ahead.
Yeah, Dr. Book, thank you for this wonderful talk. It's very educating for me. I'm a PhD stem cell scientist who is very enthusiastic using stem cells to treat a single ventricle patient. So we collaborate with Dr. Elder to address this issue. So I have a question about your perspective. So in clinical trial, there are some kind of thinking about utilizing patient bone marrow cells or stem cells to enhance the functional ventricle to eventually boost up the single ventricle function as a potential therapy. So I want to ask your perspective about that. And the second quick question is about what are potential genetic mutations that may be correlated with this single ventricle patient? So we could think about congenital, maybe gene therapy. Thank you.
I'm not aware of any single gene mutations that would be candidates for therapy for single ventricle patients. There are some genetic associations with hypoplastic left heart syndrome that may lead to some possibilities down the road. Stem cells are interesting, promising. If we can improve the function of that single ventricle, perhaps we can delay Fontan failure. I agree with you. I think it needs to be done early in childhood. I'm concerned it would not be particularly effective once the adults have developed extensive fibrosis. But perhaps at the time of that original operation is early enough to make a difference. And I'll be curious to see what you guys learn from that.
Yeah, I may make an appointment to share with you our progress, research progress. Thank you.
Thank you.
Great. Well, in the interest of time, it's 9 o'clock. So I just want to take one more time to thank Dr. Wendy Book for joining us for our grand rounds and wish you all a good morning.
Thank you all. Thank you for having me.